Okay, so it's very practical. So we have basically 53 years old lady from the Middle East who is sent to your clinic for evaluation from the neurology clinic. So these are, of course, all of these cases are real. Her past medical history was significant for a diagnosis of ovarian cancer in 2008. She was treated with surgery and chemotherapy. She underwent an active follow-up with multiple repeated abdominal CT scan with intravenous contrast during the following years. Everything was fine. She was following in Zayed Military Hospital till 2012 when she decided for since the other hospital was closest to her home, to do the CT scan in a different hospital, so a private hospital in Abu Dhabi. And she reacted. Okay, she had a bad reaction. She had shortness of breath, generalized rash, and edema of the face, and her blood pressure dropped. So basically, she had an anaphylaxis during the investigation. She was admitted to the hospital, so it was severe enough to warrant admission to the hospital. She was in the ICU, discharged after 4 days. So she went back, said, like, okay, bad choice changing the hospital. Let me go back to my previous doctor. And she repeated the CT scan there. So they decided to do a premedication, but she reacted again in a very similar way with generalized symptoms and hypotension immediately after radiocontrast media administration. So after the second reaction, she never repeated a CT scan with contrast. So basically the solution was, okay, let's avoid the contrast media. Everything was fine till 2021 when she was seen in cardiology at CCAD for a non-specific cardiac symptoms. So mild pressure, shortness of breath, reported during physical exertion. The ECG showed a left bundle branch block, and there was no history of previous ECG available, so they didn't know if it was new or old. So they said, okay, that would be great to see our coronary arteries. We could do a cardiac CT or a coronary angiography, but the problem was the allergy, of course. And also during the same period, she was investigated in neurology for a headache, an episode of blood revision. She did an MRI, showed the left MCA critical occlusion. So the neurologist gave indication for angiography. So we had two reasons to perform two different investigations with radiocontrast media. All these investigations were put on hold due to her history of radiocontrast media reaction, and she was referred to us for further investigation. So you see, there is the need. Nothing was done till now. Now that the investigation is needed, everything is blocked because it was not previously investigated. So she was seen for the first time in the allergy clinic in September last year. She was a very pleasant lady, very smart. She didn't have any ongoing medical treatment, so she was well overall, apart from this investigation that were prescribed. Except for a low-dose ASA aspirin, she was recently started by the cardiologist as prevention. So there was no history of atopy, no asthma, and no previous reaction to other drugs or medication. She did not have any documentation of her previous reaction. She tried in the past to obtain her records from the private hospital in Abu Dhabi, but they refused to provide it. And this is really a common thing that I cannot really understand. And it's really making our job very difficult in drug allergy investigation. At the end, they said their child was no longer available. And so she didn't manage to get her previous medical record. So, no, wait. So, sorry, this is not. So what she had. So let's see how to proceed to the investigation. So basically, we have to understand first the type of radiocontrast media hypersensitivity. The type of contrast we have. So basically, we classify them into two big families, the ionic and non-ionic iodinated radiocontrast media. So the ionic are the older one, and mostly no longer used. Further classification into their structure, monomeric and dimeric. So mostly what we use right now are non-ionic, and most of them regarding the osmolarity or level and the dimeric are basically in the group of the monomeric with low osmolarity, even if like the isoosmolar agent iodixanol can be used. Of course, the risk is different. So the ionic contrast media have a higher incidence of immediate hypersensitivity, up to 13%, while the non-ionic have a lower hypersensitivity rate with 0.3 to 3%. So first of all, the non-allergic reaction, adverse event, non-immune mediated are very common and predictable. So most of this thing can be explained to the patient, who can interpret her symptoms and avoid unnecessary avoidance in the future. So they might expect flushing, palpitation, having generalized body ache. This is very usually mild, does not warrant like a hospital admission or even further investigation, and are self-limiting. Hypersensitivity reaction tends, when they appear, are mild to moderate, but of course also severe reaction are possible. So immediate type, usually they occur during the exam, so immediately after the intravenous contrast administration and up to 1 hour after the procedure. They were classically considered to be non-IgE mediated, but now increasing evidence is available that are actually most of them IgE mediated reaction. Delayed hypersensitivity from 1 hour to several days after the procedure, most of these are T-cell mediated. So there are risk factors to radiocontrast media reaction, hypersensitivity. So first of all, the repeated administration of the agent, a history of other drug allergy to other drugs, comorbidity like cardiovascular, chronic kidney disease, other specific one to the atopy, so asthma, having diabetes, multiple myeloma, some specific medication, and being in the female gender. So classic manifestation, urticaria and generalized erythema are the most common one, bronchospasm and dyspnea, and also, of course, decreased blood pressure, shock, angioedema. So the immediate reaction, they should not be confused, of course, with the non-allergic reaction. So the doctor should be able to differentiate these. Are usually from few seconds to few minutes, most of them within 30 minutes, to be honest. The treatment is, of course, as for the other immediate type reaction, most of the time for the milder reaction are self-limiting and no need for the treatment. There is, okay, let's move on. Delayed hypersensitivity are increasingly recognized. And since most of them appear like several days after and they are mild, they are most likely to be unreported, okay? So most commonly a maculopapular rash, there might be a delayed urticaria with angioedema, and more severe reaction are rarer. So these, of course, example of the strife, of the classic maculopapular rash, AGIP, and like to the top of the severity scale 10 and Stevens-Johnson syndrome. So evaluation and management of the immediate hypersensitivity reaction to radiocontrast media should be well known by the allergist. So any reaction should be that is thought to be true immune mediated should be further investigated. It's better to wait the classic 3-4 weeks before starting investigation. For patients who requires urgent radioconjugate media administration, there are specific recommendations like selecting a different agent and using a premedication. So for the delayed reaction, usually milder reaction don't necessarily mean to be investigated. Most of the time, they might not happen again, even with the use of the same agent. For the severe reaction, of course, exclude one of the most severe scars, so DRESS and Stevens-Johnson syndrome. A biopsy can be used to confirm the diagnosis. And if allergy investigation is warranted, wait till the reaction is completely subsided. So what do we do with our patient with suspected radiocontrast media hypersensitivity? Skin testing, first line, of course, skin prick test, intradermal test. For the delayed reaction, we have the intradermal delayed reading and patch testing. Lab testing, not available right now here, at least to my knowledge. BAT, so basophil activation test. which is useful in the immediate reaction, but not in the delayed one, and the lymphocyte transformation test that is very rarely performed, and the drug provocation test. So these are the possibility we had with our patients. So skin prick test and the intradermal test with immediate reading. We might perform in a different setting basophil activation test and the drug provocation test. These are the concentration which are suggested for skin prick test and intradermal. Please note, for very severe reaction, you might consider using a lower concentration for intradermal testing as a starting, and if negative, move up to 1 to 10. So in immediate type reaction, if performed in the correct time window from 2 to 6 months after the reaction, the positivity rate is quite high. So more than 50% show a positive skin test, while after that period, the chance of getting a positive skin test drop. So these are like recent guidelines published by the Allergy group. So basically, if you have clinical signs of hypersensitivity, first you put basically you grade the severity. If we have a systemic, if you have a systemic signs and symptoms suggestive of a drug anaphylaxis, you have to consider if you need to repeat. Like imagine like a patient who needs coronary angiography. So if you have to repeat the administration of the contrast media, you have to follow these guidelines. So try to avoid as much as possible. If indispensable, consider using a different contrast media, pre-medicate the patient, advise the presence of like an anesthetist so that can intervene in case of reaction. So if, of course, the reaction was not severe, but the contrast media is needed, all of the above, but without like the necessity of high intensity monitoring. So if we don't have in the position of need, like the fact that we don't need to repeat it immediately, we have time to investigate. So skin prick test, intradermal, and BAT, of course. So if negative, they say, okay, it's unlikely that she had really a reaction, but of course we can't be 100% sure. So I suggest to eventually move to a drug provocation test. Okay, if there are positivity and we want to see if the patient can tolerate other agents, again, a drug provocation test can be done in those agents who tested negative on the skin. So which are the pros and cons of different strategies? Of course, safest is completely avoidance. It's safe. We don't have the diagnosis, so we don't know anything about what happened. And what's the problem? Okay, patient might not be able to access these diagnostics in the future. Use of premedication. Advantages, very easy to do, but breakthrough reaction are present. There might be a false sense of security. You might lose the first signs of reaction if you premedicate the patient. There is no consensus. Americans say no, don't premedicate. Europeans advise for premedication. There are possible side effects. I don't see like the big problem with the expenses. Anyway, the comment, the evidence of its efficacy is very weak. It's probably not really helpful if you are trying to prevent a severe allergic reaction. And of course, there is no consensus. So alternative by clinical history. So if you know which agent reacted, caused the reaction, use another one. But like there is weak evidence. And of course, it's more effective compared with the premedication alone, but many times it might be difficult and you might have cross-reactivity. Selecting an alternative agent by skin prick test, skin test negativity, there is a high negative predictive value. It's likely that you can select contrast media with low chance of cross-reactivity, but it's time-consuming to go through all the records. You need the expertise to evaluate this patient. And of course, it might not be able to predict non-severe or delayed reaction. It's 15 minutes now, so let's move on. there is increased evidence, okay, in Europe might be recommended. But what is recommended is an alternative selection by drug provocation test negativity. And we'll see. That, of course, has some advantages, which is so let's say the most precise method in identifying the possibility to tolerate the agent. But of course, it's very time consuming. It requires hospitalization, and like it has some risk, of course. So what we did in our patient, skin prick testing, very important thing to do. So don't do the skin prick test only to the agents which cause the reaction, but include all the available agents in your setting. Okay, so these are the ones we have in Cleveland Clinic. So Yoaxol, Yoversol, Yopamidol, and Yodixanol. Everything was negative, not a big surprise. The reaction was like 9 years ago. Intradermal test showed a borderline positive reaction. So the original bleb of 7 millimeters increase of 3 millimeters, which is exactly the threshold to consider a reaction positive. This is very important. When you read a drug test intradermal, if there is a bleb, it's normal. So you have to circle the first original bleb that comes when you inject the intradermal agent and measure an enlargement of at least 3 millimeters. Yodixanol was considered negative as the increase was not enough. So we have Yopamidol, which is borderline positive, and another one which is negative. The other are negative. Okay. So which is the chance of cross reaction? There are many studies on this. Few agents showed a very high chance of cross reacting. So Yodixanol and Yoaxol are those. These are frequently associated, and these other agents have a lower chance of reacting. So our patient basically had a mild positive or borderline to Yopamidol, and we see that Yopamidol, it has a low chance of cross-reacting with other agents. While these two, which we have available, are frequently cross-reacting among them, were tested negative. So I did a drug provocation test in this patient. This is my scheme. I made it up, so we don't have like reference in the literature. There are multiple schemes. None of them was really validated, so I decided to just make some my own, in which you have progressive volume till you reach a total administration of 100 ml, which is like a reasonable dose. Okay, so the steps are done at 20 minutes interval. The patient is monitored in the Allergy clinic. She has, of course, an IV line, and the allergist was readily available for intervention if needed. So, precaution, of course, you have to explain clearly the risk. So there is a chance of a reaction. This reaction might be bad, okay? So if the patient wants to proceed, then be sure that your setting meets the criteria for like a quick intervention if needed, and you have the necessary expertise to do this. And consider always, if your clinic is not the right place, the patient can be admitted and can do this procedure as an inpatient. So, a conclusion of the case: patient underwent drug provocation testing in our clinic and completed it without any reaction. So she tolerated a full dose of IV contrast media with an alternative agent, since we didn't know what was the original one, and she was able to tolerate it. The recommendation for the next radiological procedure are use the agent that she was tested on and she was able to tolerate. Always consider this procedure at very high risk. Involve the anesthetist in the decision making. The anesthetist should be alerted and be ready for intervention. And avoid in the future procedure, so like a CT scan with contrast in an unsafe setting. So avoid small clinics. And to consider the premedication even with contrasting evidence. Okay, can you hear me? Yes. So yeah, here we are. So this is it. Yeah, it's fine. Okay, so basically, what is important to know in this case? First of all, allergy or hypersensitivity to radio contrast media should be investigated. So it's not something that we can just discard as like, okay, avoid in the future any kind of investigation involving iodinated contrast media. Safe alternative can be found, and so it's something that we can decide to do and can help a lot the patient in receiving the correct standard of care. And be sure you have the correct expertise and setting to perform all these required investigations. Then, if there is any question, I'm happy to reply. Otherwise, we can move on.
Excellent, Fulvio. Thank you very much indeed. Very, very nice talk. Thank you. We have a few questions.
So about the premedication, again, there is not a standard consensus of this, but like very easy thing to do is do a 2 or 3 step premedication starting 13 hours before. This might change if the patient is admitted or if he's at home. So I generally write an oral steroids like prednisolone 1 milligram per kilo up to a maximum of 60 milligram on like time 0, so 13 hours before and 1 hour before the procedure. And or even you can do the 3 dose if you have like a high index of suspicion and an antihistamine. And for outpatient, I generally write a newer generation antihistamine. Like, the only difference is that with an older generation, you have the parenteral form and decide to do the last dose just soon after before, while like with cetirizine or any other, you need to tell the patient to take it like 1 hour, 1.5 hours in advance, so you're sure you're reaching the time in which it's absorbed from when they will have the exposure to the contrast. Yeah, I mean, the patient will react. So if she had an anaphylaxis, yes, it will react. I would not trust to take the chance of like doing it if I'm not sure the patient, let's say, had a milder reaction or there are no alternatives. Okay, so I would not rely on this kind of medication to prevent an anaphylaxis. To prevent urticaria, yes. To prevent angioedema, yes. To prevent an anaphylaxis, no.
For those who have urticaria, maybe they will anaphylaxis, they may not do.
Yeah, the problem is, yes, it might work. The risk is you mask the urticaria and then the patient develop like the hypertension because the steroids or the antihistamine are not able to tackle that. But yes, I mean, of course it works. Otherwise.
More questions? Excellent.